So welcome to the public governing body of NHS Devon CCG on this, the 18th of June 2020. This is a meeting in public, although it is not live. We hope that you will get, if you are a member of the public watching this, that you will find it a valuable experience to hear about some of the work that we on behalf of the NHS have been doing within Devon and have to do in the coming months. So welcome everyone. Nikki, do we have any apologies?
Paul, the only apologies is Virginia Pearson and Tracy is joining for today.
Okay, thank you. And welcome Tracy. Can I just say that Tracy has attended for Virginia most of our, if not all of our governing bodies for the time that we've been Devon CCG, but this is your last one, isn't it, Tracy? So you've got much better things to do with the next many years of your life. So we would normally have a gift and a card to say thank you. It's a little bit difficult to do virtually, but what I do have here in this bag, there is a bottle of wine which will be by Nikki's desk in County Hall. So as long as you can get here before it goes off, then please do come and collect that as a thank you from us at the governing body. Your presence has been way more than just making up the numbers because Virginia can't be here, but you've been really good at representing the people of Devon. You've been really good at bringing that public health agenda and the challenge that we often need in order for us to have the right conversations and come to the right decisions for the general population. So thank you, Tracy. I hope this governing body is as enjoyable as all those other ones that you've been at. And I wish you all the best going forward. So thank you very much.
Thank you, that's really kind, and I will definitely make a trip in. I've got to come in to clear my desk anyway, so I will come in, clear my desk and pick up wine. I think that'll be one of my favourite visits to County Hall. But thanks very much.
All right, thank you very much, Tracy. So item 2 is the register of interests. Can I ask people if there are, I'm slightly distracted because all the messages of thanks are coming through on the meeting chat at the moment. So I'm going to switch that off so it doesn't distract me. But Tracy, they are well worth a read for you to peruse. The register of interests, anything that people need to add, adjust or amend in those? And any interests pertaining to items of the agenda that people would like to highlight? No. Okay, that's good. So then we come to the meeting minutes of the last meeting, and I am working from overall pages of 163, which I think is the most up-to-date board pack, but someone let me know if it's not. So I'll take them page by page. So page 10 and 11, 12 and 13, 14 and 15, 16, 17, 18, 19, 20 and 21. And then we take that as we've got, yes, sorry, that was just another comment coming up there. We've got that as an accurate record of our previous meeting. And there were no actions from that and no outstanding actions, so we don't have an action log that we need to go through. Okay. So the next item is the chair's report. So as you can, I'm going to take that as read. I'll answer any questions relating to it. But I guess the thing that I want just to highlight in this our public meeting is just the extent to people have gone above and beyond and had to have adapted to new ways of working and done things so differently and done them so well that it's not just me in this chair's report saying thank you to everyone in the CCG and in the wider NHS, but that's been echoed by others in meetings that I've been in. It was echoed in the Overview and Scrutiny Committee of Devon County Council earlier this week. Our MPs have been hugely supportive of us as an NHS in the engagement that we've had with them, and of course our public have been very supportive in their rainbows and their posters in their windows and their Thursday evening applauds. So that's and so I would just like to say a thanks to everyone who's been involved. Sorry, there was a pause there because my computer has just gone. So I will leave it there and see if there are any questions that anyone would like to raise or any comments. Then in which case we will take that as read, and I'll hand over to Simon while I try and sort my computer out and to the accountable officers report.
Okay, thank you, Paul. So I'll take it as read, my report as well. Happy to take questions. I just wanted to draw out a few things. So under the workforce section, just a reminder to governing body that we redeployed 120 people from our CCG staff. That's to external agencies, not just inside the CCG in terms of our incident response. And to note that we've got a project team in place to plan for a return to the workplace to make sure that it's safe and fit in the new world. So if you've popped into County Hall, you'll see yellow and black tape around desks, etc. I wasn't going to say anything about the testing, although it might come up as in questioning. The only point I was going to make, it was around test and trace, and by the end of June, so next week, we have to, or the County Council and the other local authorities need to submit local outbreak management plans under the guise of the Directors of Public Health. In Devon, in the County of Devon, Devon County Council and Torbay will be submitting a joint local outbreak management plan, and Plymouth's will be separate. And Ruth and Caroline and Tracy, I'm sure, are aware of that. There are a number of groups required under that local outbreak management plan. So Health Protection Board, which the DPHs will chair, and I'm going to sit on both the Plymouth and the Devon and Torbay one to provide some NHS support. And there is also an engagement group which is politically led, so again chaired by Steve Darling from Torbay, John Hart from Devon, and Tudor Evans in Plymouth, and Paul will be sitting on the Devon and Torbay group. The next bit was just about care homes. I just wanted to draw governing body's attention to the CCG trainers that we've offered infection prevention and control training to all of the care homes across all of our local authority areas. We had a very tight timescale, so real thanks to Philip, Darren and the team that were supporting that there were a number of sessions put on over the bank holiday weekend to make sure that we hit that target. A note really to Andrew and the comms team that our social media activity has reached over 1 million people. So 566 posted messages. That's on all the bulletins that we've done to our clinical colleagues across the county in secondary and primary care, and our staff bulletin. So our social media has been attracting quite a lot of interest. If I move on from COVID now to the segmentation or the oversight framework from NHS England. So previously this would have been our annual assessment, and we'd have been rated. So we could have been rated outstanding good, but generally we were in the requires improvement category. But just wanted to draw your attention to, even though we know we've had a challenging 12 months and both performance and money have been very difficult, we were actually rated as segment 2, which means that we would receive targeted support. So that is, there is only one segment above that, so maximum autonomy, and that means that the support that we would receive is agreed with us and our regulators to make sure that the support is in a really targeted way. So you'll all recall that both previous CCGs spent time in legal directions, which is segment 4. So I think there's actually a really good trajectory there. That's all I was going to say, Chair, and then I'll open to any questions that people have got.
Thank you, Simon. So Judy.
Well, firstly, well done to Simon, the team, Paul, and everyone for moving up to 2 and their targeted support. And that, I think, you know, is a good sign, because whatever the problems, you have been showing great leadership. I have a question about, it's on page 5 of your report, about this PPE issue, because you tell us that you think, the CCGs think it, you know, the cell should continue, that the issue isn't resolved, and that the local resilience forum, sorry, I'm not quite sure who that involves, thinks we should stand it down, but you don't really leave us with a conclusion on that. And I know how big an issue PPE is for everyone. And as you say, it's extending out as other parts of the community try to open up schools and things like that. So could you just tell us what's happening on that, and whether whoever these LRF are listening and keeping it open?
So the local resilience forum is chaired by the police. It's a statutory body that comes together in incidents. So police, fire, health, local authority. So we felt we needed to keep the PPE cell open as we start to stand up services, so we can continue to monitor whether our health services, particularly our acute providers and primary care, have enough PPE to be able to deal with whatever the new normal looks like as we stand up services. That was less of an issue for police, local authority, etc. So we decided to keep our CCG cell open, and if needs be, we can go back to the LRF to ask for further support. But at the minute, we feel that we can contain that within the CCG.
Thank you very much.
Nick. Nick Ball.
That's another pound. Sorry, Chair. Simon, I've just been looking at the death rate as a proportion of the number of people who are infected, and Devon is almost precisely consistent with the average for England in terms of that proportion. But compared to the whole of the UK, we're dying at double the rate. Do we understand what is happening differently in Wales, Ireland, and Scotland that is depressing their death rate?
So short answer, Nick. No, I don't know. And before, I won't throw a hospital pass to Paul or other clinical colleagues. So no, but we can go and have a look at that. In terms of the death rate per incidences being average, you would probably expect that given our demography, wouldn't you? So I'll have to come back and answer that, Nick, I'm afraid.
Okay, all right. Thanks, Simon.
Okay. Any more questions for Simon? Okay. Simon Kerr.
Yeah, Simon, there seems to be a capacity issue with phlebotomy developing rapidly, and I have had requests from my local acute trust to try to support them with phlebotomy from primary care. Can you comment on that and the imperative which we seem to have for providing back to I guess NHSC, NHSI numbers of people tested and how we might manage that?
Yeah, so it has become the rate limiting factor. So as you know, Simon, before there were some issues around reagents, lab capacity, etc. Now phlebotomy has become the rate limiting factor across the whole of the Southwest. I haven't asked whether that's an issue nationally. So it's some work that the out of hospital cell with Regent under Ian Biggs that is looking at. I don't know whether Joe wants to comment in terms of the work she's been doing, but so we're aware. I'm not sure we quite know what the solutions are to that at the moment. So we know that that's something to solve if we want to increase the number of tests. Joe, was there anything you wanted to say?
No, probably nothing to add to that at this point, Simon.
Okay, thank you. Thank you very much, Simon. So our next item, item 6.1. Joe, we're expecting Liz Cosford to join us.
Yes, Yeah, I was just going to say we are, Paul, but it's sorry, I was just texting her actually to see if she could join us earlier, but we are a little bit early. So can I suggest we take one of the other items first?
Yeah. Okay. So Simon, do you want to give us a briefing regarding future plans?
Yes, happy to, Paul. How long do you want me to fill for this item? So I wasn't going to say a lot, but I'm happy to have a set of conversations. So as I referenced in my report, we're already looking. We have a project team looking at how we can return to our physical environment. But I wanted to let governing body know that we're also making sure we look at the people side of things, and also our priorities and objectives as we move into what's the new approach for the CCG and indeed commissioning as a whole. So I've done some work with the directors, the executive directors last week to start to look at our priorities as we move into phase 3, hopefully from the 1st of August. We're still expecting a letter from NHS England and our national regulators. But about what are the things that we need to make sure we have in place. So we've learned quite a lot through the pandemic, and you've heard me reference before things like our cell structure, our ability to focus on a fewer number of priorities to actually get things done, move on to the next item, and that's something we want to capture. But we've also know that the health service and where it integrates with social care is very wide ranging. What we agreed at our time out was that we really set our priorities properly. We need to properly understand our population. We need to make sure that we are utilising best evidence and research, so that then we should be able to set priorities locally that are really important for the population of Devon. And that may mean that we need to set up the organisation in a slightly different way than our traditional directorate structure. So again, you've heard me mention, and interestingly above your left shoulder, the commissioning cycle. So we want to make sure that we can suitably support our localities and places, that we have enough expert knowledge around things like elective care, mental health, which will be the presentation that Liz and Joe do in a minute, but also that we are capable of providing that commissioning expertise of all of the commissioning cycle. So not just the contracting or the monitoring, but the strategic planning, the evidence base, the proper service reviews. So those are the sorts of things that we were talking about as an executive group. We've got another timeout session in a week's time, I think it is. But my intention would be to bring back a proposal, a draft proposal or a discussion document, to have some development time with the governing body to really work through that. Because we've said on a number of occasions, and certainly through some of our development sessions as a governing body, that whilst it's very important to focus on assurance, there's also the two other aspects of a healthy board around strategy and around culture. And we're trying to make sure that we can give you a proposal that starts to get into a real discussion around those two elements. So that's all I was going to say about that. Yeah. I don't know if I filled enough time, Paul.
Well, no, I mean, the only thing I was going to ask Simon on that is because, you know, and it's a public meeting that talking about how we restructure ourselves and using cycles and those sort of things, just try to articulate the benefit that the population will get if we get this right and if we organise ourselves and work in the way that you want us to, that you were describing.
So as I said, really, Paul, that we have, and we've always had joint strategic needs assessments, but we tend to utilise them on specific issues. So if we get a national priority, cancer would be a bad one to choose, but if we get a national priority around learning disabilities, we would then do a needs assessment, etc. But what we don't do, I think as well as we should, is understand all of our population and all of its differences and demography. And we also need to do much more work around our evidence base. So as you know, and all governing body know, we have a clinical effectiveness team that is absolutely excellent in how it judges evidence, but its focus at the moment is purely around the items that come out of NICE, really. So how can we use that sort of process and that sort of skill set to be able to look at evidence around, for example, community services? So community services, we don't have a lot of data about, and Sarah may mention this when she comes on to the performance report. But having worked through the pandemic and quite closely and very heavily focused on it around discharge, our knowledge around community services as a commissioner is not as strong as it should be. And those are the sorts of things that we really need to make sure we understand, and that we are monitoring and looking for best evidence across the globe, really.
Okay, no, thanks. That's really helpful. Glynis has got a question.
Yes, when we had our meeting in Plymouth last year, Simon, and I can't remember what time of year it was, we looked at our commissioning intentions, and I just wondered at what point we would review those or refresh those, you know, as part of this future planning.
Yeah, so I think that is over the next couple of months, Glynis. So those are the sorts of things that we reviewed in terms of our long-term plan. Look back, and so Penny, who was obviously the major author of that, was present at our time out, and we were looking at the priorities that we set as a system in the long-term plan, including our commissioning intentions. Are they right for a post-pandemic health and care service? So that will be part of the proposal and the discussion document that we will bring.
Okay, thank you.
Okay, Nick Kennedy.
Yeah, sorry, can you hear me now? Can you hear me?
Yes.
Yeah, sorry. Thank you. Simon, yeah, as I'm sure you know, I'm very supportive, very keen on using the evidence-based decision making. I think that's really, really important. But what a number of other places are doing is sort of expanding that and using a loosely called a value-based approach, which is evidence plus looking at the outcomes and overall value, which, given the economic situation and the very large demand there is at the moment, I think is something we should probably look into as well as part of our ongoing thinking, to build on the evidence stuff. And there is plenty of stuff out there that other people are doing, particularly in South Wales, from what I know. But just as a suggestion, I think we should look seriously at a sort of value-based approach as well.
Completely agree, Nick. And it's almost like I could have emailed you to say, please, can you ask me a question about this if I forget? And I can see Mr. Dowell in the bottom right-hand corner of my screen. So John and I had a particular conversation about how do we take finance and value for money forward, given pre-pandemic there was the system finance report, and one of the recommendations was about really understanding what we're getting for our money effectively, and the CCG being a proxy for the population at large. So one of the things we were, John and I were talking about, was if we have our population health management process, and we're looking to implement that, what are we going to do with that? And so John and I have started, my words, not his, but how can we have a proper actuarial analysis of what we're currently spending our money on with our population, and if we were to do some different things, what value would that have, both in outcomes and in cost effectiveness? So that is part of it. John and I don't quite know how we're going to do that, and we've been talking about possibly using some skills that we might have seen in insurance companies, for example, about that real actuarial analysis of what we know about our population. So it's in there, Nick, but it's not fully formed by any means.
No, I'm sure. No, that's very reassuring. Thank you.
And then Simon.
So Simon, you've talked a lot about population health management. If you remember, we looked at right there and how we might use the data that we were looking at, particularly with regard to QOF and right there in the past, when we had a gap, when I think one of the years we suspended QOF. Have you thought about the potential implications for understanding our population, given that we've got QOF suspended at the moment? And if and when do you think we might be asking primary care to step up at QOF at some point, or do you not think we'll be doing that this year?
I'd bow to Joe and Judy and others about the conversations they've had about QOF, and I've seen Sheila's hand go up, so hopefully they've got some more intelligence about that, Simon. So I've not considered it, but what we have talked about is standing up the population health management programme over the next month or so. Paul O'Sullivan's working with the national team on how we can start to do that. But absolutely, our demography is going to have changed, isn't it? We're lucky that we haven't had a lot of incidences, but actually we will have some change in it, so we'll need to re-understand that. But I don't know if I don't know who you want to go to, Paul, to see if anybody else has got further information.
Joe, for you around QOF, but let's not go down this line too far, otherwise we'll be a long way away from getting back to the mental health agenda, because I know that that Liz Cosford has now joined us.
Yeah, thanks, Paul. I'll be really brief. So there's nothing additional at the moment coming out nationally, Simon, apart from what's already been said. So the latest updates, the latest letter that came out around phase 2 to primary care was a really clear message that clinical judgment has to be made, but do as much as you can do. So it's not that QOF is completely stood down. In fact, was never completely stood down in some respects. It was just a recognition that some of it wouldn't happen, and that time and resource could be diverted into supporting COVID. So I think by and large, in quite a lot of practice, some of that is already being stood back up now, but we will have to wait for further national guidance. All right.
Thanks very much, Joe, and thanks, Simon. I'm sure we will get more information around the future plans as they develop, as you described, when you've been through with the execs and we have that time as a governing body to further consider it. Let's go back to item 6.1. Liz, welcome. I think James is going to co-present with you. We've got the slides available in our packs. So I'll hand over to you, Joe. Did you want to say anything by way of introduction?
I will be really brief. So the reason for bringing this here is because there was an action from the private governing body last month, real keenness for our governing body to understand what are the impacts on our population and our services of COVID. How have we responded to that, and how are we planning for the future? So I think it's really pleased that our governing body is interested in that as a real priority for us. So we're going to assume that people have had a chance to read the slides because there are quite a few, but Liz and James are going to pick out some key points, and hopefully with a couple minutes left for questions at the end.
Yeah, that's great. Hi, James.
Hi, Liz.
Hi, thanks everyone. So I'm assuming that the slides aren't being shared on screen. I'll just talk them through. Is that okay? Yep. So
yeah, that's fine. And I may, if I can share some of the slides, I will do. But otherwise, we've got the packs.
Okay, that's great. Thanks very much. So, well, thanks very much, as Joe said, for inviting us here today to talk through the impact of COVID-19 on the mental health of our population. And as Paul said, James Wooldridge, as non-exec director, is going to jointly do this presentation with me. So the purpose of today is to answer 6 key questions. What is the impact of COVID on the mental health of our population, the potential impact anyway? What are we expecting to see? What we are seeing now and what we are doing in the future? Can everyone hear me okay? I'm getting a bit of rebound.
Yeah, I can hear you, Liz.
Okay, thank you. Thank you, Paul. Who's got control? Is that you, Paul?
Yeah, I have. So just let me know when you want me to move on.
Okay, so if you could move on, that'd be lovely. Thank you. So in order for us to answer this question, we've reviewed the learning from previous similar events. Other pandemics and the impact of economic recessions are the areas where we have most evidence and information to work on. And if you take a look at this slide, The Lancet published in a paper in April of this year that summarises the impact that epidemics and pandemics are known to have had on mental health in the past, and have concluded within those 3 boxes, you'll see that the consequences are likely to be present for longer and peak later than the actual pandemic, that the pandemic will cause distress and leave many people vulnerable to mental health problems and suicidal behaviour, and that those with mental illness might experience worsening symptoms. All these things are critical. This evidence base is critical to how we have been looking to manage our system now and as we move forward to phase 3, which we'll talk about in a minute. The next slide, if we could just move to the next one, which just demonstrates that we also know that the social economic recession that we are likely to have will also have an impact. And if we move on to the next slide, which I'm not going to dwell on, but this slide just describes a ripple effect from the direct personal impact of COVID-19 through to the wider societal economic issues and the impact on our population, including the increased volumes, acuity and needs that we're likely to see in our population. If we could move on to the next one, thank you. So what are we expecting to see in our services? National Centre for Mental Health's first assessment indicates that 500,000 people are likely to have mental health problems as a result of COVID nationally. So that equates to about 2.5% of the national population for Devon. And at the top end, that's about 12,500 people that we are expecting to see in addition to our services. So that, as you know, will increase the demand into our services. And if we look at this slide, what are we expecting? Which is a bit of a brain gymnastics slide, so apologies for that. But if we break that down, you can see that the pink wave, so this describes the type of need that we are likely to see and what we think will happen to the volume over time. So if we break that down and look at the pink wave as an example, this describes the suppressed needs during COVID. We've seen a reduction in referrals across the board for planned care. So some of these people have waited longer, so they might be more complex than when they were first referred or had an identified need. If you look at the yellow wave, the social impact, again, as we come out of lockdown and the lockdown measures are reduced, the impact of that social isolation and social measures is likely to be felt. And again, people will present with their mental health needs. The purple wave is the demand linked to trauma. And you'll see that's a lower curve, it's a lower sustained curve for a very long period of time. So it's smaller scale, but long-term impact for trauma people may present many years after the traumatic event. And if you can equate that to some people that have been to war, they don't all present at once, and there's a trickle effect ongoing. The blue line's around complex bereavement, and the green is around the socio-economic impact. Happy to move on. So James, I think you're going to talk us through about what we're currently seeing and some of the evidence so far on a national basis.
Yeah, I will do. So this should be slide number 11 you're seeing now, with the national picture and many of the statistics and percentages showing a majority of increases. Now, let's look at these in a bit more detail. I was looking at the highest numbers first. So a lot of the substantial increases around sadness, sleep difficulties and pressure linked to a new work culture. I think many of these might be classed as low-level mental health need. And what's interesting is that as much as we've seen within statutory services a lot of collaboration between our service providers, we're also seeing the same in the voluntary and third sector. So I feel that many of these low-level issues can quite easily be signposted across to the third sector, and perhaps by doing so via our network of social prescribers and community connectors, we can then perhaps see that we can reduce the strain on services going forward. I was also looking amongst these figures for some particularly good news, and I'm not sure if this is good news, but I looked at the figure for adults with severe mental illness over on the right, and it says a quarter have said that their mental health has got much worse. But on the other flip side, I'm seeing that then for 3/4 of the people, their mental health didn't get much worse. And I'm hearing some anecdotal evidence that says that many people who have had long-standing illnesses and been connected to services for a long time are in many ways better able to cope with the social isolation and distancing that we've seen as a result of COVID. Again, this is anecdotal, but I know for myself, a lot of people are seeing COVID as being a sort of nationwide leveller with the social distancing measures in place. So I do wonder if that's a factor in a number of people with severe mental illness remaining stable.
Thanks, James. Some interesting findings there. So if we would like to move on around what have we done so far. So what have we done? So our phase 1 response, is where we were required to rapidly repurpose our capacity services and staff to ensure sufficient critical and urgent response. And our initial response we set up the Mental Health and Learning Disability and Autism Cell. We've been working much closer and at pace with particularly with our police colleagues and ambulance services. We've reviewing the care pathway for people with dementia, needs. And we are working really closely with our public health colleagues, particularly around the review of bereavement services and suicide prevention. If we move on to the next one, so what we've done, both our organisations or providers in Devon, Livewell and DPT, have implemented this common prioritisation framework, which adopts these 5 key principles, which I won't go into, but just to show that they both have implemented the common prioritisation framework. And in terms of our mental health system response, what we've done during COVID is, in particular, is restructure our inpatient provision. We've accelerated our urgent care provision. We've adopted our use of digital platforms and are one of the highest users for Attend Anywhere in the Southwest. We've maintained our children and young people's mental health services, and for our community mental health services, both organisations have restructured their provision to ensure they are resilient. They've risk assessed their caseloads, supported people that need medication so they're safe, and are using digital and telephony support in a much increased way. In terms of phase 2, which was the second, this is like the second part of moving towards recovery. This is around stepping up of our non-COVID urgent services in response to the Simon Stevens letter. And we did an initial assessment which demonstrated we were compliant originally in 6 out of the asks, 6 out of the 8 asks. There were 8 asks, and we're actually 7 now. We're actually compliant in 7 areas now, with 1 where we're progressing, and that 1 is particularly around the annual health checks for people with learning disabilities. And in terms of moving forward to phase 3, which is our recovery, we're building on the learning from COVID so far. We're continuing to strengthen our partnership and collaborative working, and this is going to be key in terms of our efficiencies across the system in the future. We're reviewing our uptake of digital. We're undertaking a robust demand and capacity modelling process, making sure we understand how much potential capacity we have to meet future demands. We obviously don't know, we can make some predictions based on previous experiences around what demand we're likely to see, but we equally need to know how quickly we can step up capacity if the demands increase and where that capacity is. We're reviewing and evaluating our service changes, and what's really important around this is to ensure that patient experience is captured within this as well, and we're assuring ourselves that they're based on the needs of the population. So in summary, the mental health needs, our mental health needs are likely to increase significantly as a result of COVID. I think we've got strong evidence for that, and we anticipate that the level of need and demand will remain over a period of time. We've operated effectively in phase 1, rapidly applying the implementation of national guidance and rolling out the new altered provision to support people in Devon and our system partners. And we're working together in an integrated way through the Mental Health and Learning Disability and Autism Cell to prepare and deliver the phase 3 ask. And that is, so happy to take any questions. James, I don't know if you'd like to add anything in.
Nothing other than, yes, although we are anticipating an increase in demand, I think it's going to be important going forward that links are strengthened with the voluntary and the sectors that can provide a lot of this low-level support. If people are able to access resources from community groups and within their local areas, then that will obviously offset some of the demand that statutory services will then take.
Yeah, absolutely. It's really important. And just to say, we have started to do the stock take around what services our voluntary sectors can help support us with, and we're doing that jointly with public health.
Liz and James, thank you very much. I mean, that's a really good, really comprehensive presentation and demonstrates some really good work. And I do know from talking to primary care colleagues and clinicians within mental health that this is a growing concern of what we face. Can I just ask, and then I'll hand over to others who are waiting to come in, one of the things looked at was things that are sometimes classed as low-level mental health, but that may be managed without specialist intervention. And often primary care is the first port of call for those people. But there is the potential here for direct access of psychological therapies or for early signposting to, as we discussed, some of those voluntary groups. Are there things in place? Because I know that my primary care colleagues would feel concerned being having to manage that increase demand and the opportunity to allow people to self-refer and for them to know that that option is available to them. So there's the communication side of things would be really helpful in managing that element of the increase we're likely to see.
Yes. Shall I answer that? So yes, we are looking at that. Absolutely, Paul. It's one of our key priorities within our phase 3 piece of work, and we're in the process of establishing what the potential demand is likely to be, and how we can meet that demand and increase those services. And yes, with some of the direct access, our introduction of some of our crisis lines, we're learning around how we can assure self-referral, looking at self-referral routes into those services.
Yeah, I think the only thing, Paul, I just add to that, just for note, particularly as this is in public, of course, the IAP service, so the access to the talking therapy service is self-referral, so you can refer into that yourself without a GP.
Yeah, no, that's really helpful, Joe. I guess the point was more about how do we make people aware that that option is available to them and encourage them to use that as an effective form of gaining support. Simon.
Yeah, thanks, Paul, and thanks, Liz, for a really comprehensive presentation, and thank you, James, for bringing this to the governing body. I was really keen that we spent some time on mental health at the governing body, so it's good to have that. It's also good to have your graph. I like that, showing when the predicted increased demand will happen relative to the actual COVID scenario. But actually, James, you make a really interesting point about, in fact, perhaps the people with SMI, so severe mental illness, may in fact be more resilient than we anticipate, and the large demand might actually come from people we're not anticipating. I spent some time ringing all my patients who were shielded and was reassured that I think almost all of them were really managing comfortably, and only one of them, we set up an opportunity for all my shielded patients to have a one-off support from our Ways to Wellbeing, which is our social prescribing setup, and only one of them chose to take that up. But I think Paul makes a good point, is how do we actually help all the PCNs, primary care networks, to make sure that they have good access to social prescribing, and that indeed possibly patients could self-refer to self-prescribers to support them, because at the moment most self-prescribing setups require GP referral, and I think that the people who will need that help will largely come from areas where we don't anticipate. So there might be people who've got to get back into work, having been furloughed for quite a long time, and they're actually quite anxious about going back to work. I think we've seen that. We are seeing that both in the health and social care profession. We're probably seeing it a bit in the teaching profession. And there'll be a lot of people, I think, in the hospitality sector who, once they're faced with going back to work, they will be requiring us to support them with their anxieties and concerns around that. So I think it's great to highlight it, but I think we just need to think about how we best manage our services to meet the need that might not necessarily be coming from where we anticipate it will come from. So thank you.
Yeah, and I think that's a really good point, Simon. That sort of echoes the need to how do we effectively communicate this to the wider public, particularly since many of them may not be known to us, so we can't just do it in a targeted way because we don't necessarily understand who it is we're targeting. So Liz, I think that would be something to think about. It'd be good to consider that as part of our plan, which I'm sure you are.
Yeah, absolutely. Do you want me to respond on that? Sorry.
I think it's an ask of governing body just to make sure that that's an integral part of our, of our plan for coping with those people with some of those less severe mental health sequelae of the coronavirus pandemic. I think, Liz.
Yeah.
And Chair, if I may just pick up Simon's point about self-referral into services. I think one of the fears amongst the voluntary sector, and the reason they have they have referrals in place through GPs, is to manage their resources and their numbers. And I think although there would be an appetite for making more of their services available by self-referral, I think it is somewhat dependent on the resources a lot of those organisations have.
Yeah, James, I think that's a fair point. Yeah. Charlotte.
Thank you. Thanks, Liz and James. It's a really good presentation. My first query, comment was sort of linked to the last point, which is about the voluntary sector. And I suppose maybe looking at how it's reflected in our commissioning strategy and priorities going forward, if we are going to be looking at kind of referrals, because obviously the economic impact on many social enterprises and charities is very severe with the increasing demand, as everyone's aware. So I think it's important to kind of bear that context in mind when we're looking at that as part of the bigger picture. And the second thing was whether there was anything particularly around, I'm interested in perinatal mental health, and whether there was anything coming out from what you've done so far in your work in mental health, both low level and severe.
Shall I pick up? If I can just pick up the first point, Charlotte, because I was just having a similar thought really. So I think one of the things that we really want to hold on to and build on this across all of our sort of commissioning work, if you like, is around how valuable that community and voluntary sector input has been. In fact, it's been invaluable, hasn't it? So I think for me, there's something about how we now build on that across, as I said, all of the commissioning that we do. And taking James's point, I think, because I think, self-referral, particularly if that takes demand off the front door of primary care or elsewhere in the system, is really important. So we need to build those relationships now with those providers and really treat them as a proper part of the system and properly plan for the demand that we expect to see there. So I think that's something that we should take forward, but not just specifically in mental health.
Thanks.
Thank you very much, Joe. Let's take it in pairs. So Sonia and Alison, and then if there's any questions that come from those, we'll then go back to the presenters.
I think there was, sorry, Paul, I think there was a second part to the question about perinatal.
Oh, of course there was. Yep. Sorry, apologies, Joe.
So Charlotte, just in terms of that, in terms of our learning, we are in the process of assessing and looking at what the needs are of the perinatal services as we move forward. So we're in the process of looking at our learning from COVID and the impact that's had on the service. So it's early days in terms of what that's going to look like for the future, but it's something we are looking at in detail.
Okay, thank you. Sonia.
There's two things that I'm just bringing together in my mind. So we previously have understood more and more the relationship between mental health and physical health, particularly in terms of outcomes for managing long-term conditions and other things. And then if you think, and I know, Liz, you've been heavily involved in how community services have been working together to support populations throughout the response. I wonder whether in the community bit, we just need to understand, so what is the impact of both mental health on managing physical health and vice versa throughout this response as well? So let's not use the opportunity to take that integrated response because, people dealing with all sorts of conditions. We know there is a different impact if there's a mental health element to it as well.
Yeah, fair point. Yeah. Okay. Alison.
Yes, Liz and James, thank you for the presentation, really helpful. I'm coming at it from a children and young persons point of view, and historically it's been quite difficult to access timely mental health provision for young people. And Children's Social Care are estimating that when the schools return fully, they're going to have an intense increase in referrals for children and young people. So I just wondered if we have the capacity to meet that possible demand.
Thanks, Alison. Again, through the work that we're currently doing around our demand and capacity modelling, we are looking at that, and it's something that we are specifically focusing on in terms of the children and young people services. And actually, the discussions we've had, it's not just about the children, it's about being able to support the families, because what we've experienced through COVID is that the families have equally, we see more families affected by this, of parents and carers and guardians of living with children who do need support from the Children and Young People Services. So we're also seeing an increase in that demand. So something we are looking at in detail at the moment.
Thank you.
Paul, do you mind if I just add to that one very quickly? Because I think this is a huge issue, and it's going to be particularly a bigger issue for children when they're going back to school as well in the future. So I just thought it might be helpful because it's opportune. So we put in a bid pre-COVID. We put in a system-wide bid for particularly for support for mental health for children, but linking that in with our schools. So the local CAMS teams that we have, so the children and adolescents mental health teams will work specifically with certain schools around Devon. So we were successful in some of that as a bid before COVID. We just literally had a letter this week to say we've been successful as well for some additional support for schools in the northern locality as well. We've also got an opportunity now to do further bidding for funding to extend that as well. So I thought that'd be helpful for governing body to be aware of.
That's really good news, Jo. Thank you. David and Graham. David first.
So I just wanted to highlight some really good things that have come out of this period of time. And the first is the urgent mental health line for patients, the 0300 555 5000 number, which patients previously, for instance, would have had to get a GP referral to get into the crisis team. But now they can do it directly via that number. So that there have been some real improvements in way that patients in crisis are being managed, in my view. So it's not all negative.
Excellent. Thank you, David. Graham.
Thank you, Paul. Again, let me thank Liz and James for an excellent report. My question is stimulated by Simon talking about demand from people we're not expecting, and also from the reference, I think 5 or 6 times now, to the word self-referral. This is a public meeting, so I'm not going to go too far in what I'm going to say, and we mustn't manage by anecdote. But I'm aware of 2 cases at the moment. One is someone who's recently taken their own life as a result not of isolation, but of being forced into isolation in a difficult relationship. And that time spent together with someone who they found difficult ended in them taking their life. The second example is someone with OCD who has become so anxious about COVID that this person has taken to spending all his waking hours wiping the whole house down with bleach, such that his hands are now bleeding and his eyes are suffering from the effects of bleach. Both of these cases I don't think would self-refer. So my question is about third-party referral. Loved ones who see something happening and want to refer someone either into GP services or into mental health services. In these cases, I don't think these people knew the way into that. So is that something we can look at into our plan? Not just self-referral, but referral by concerned third parties.
Liz, did you want to come back on that latter point?
I think it's really, really important that we pick that up, and we will take that forward and make sure we are feeding that into our plans as we look at how we pick up those people.
And just to add to that as well, Graham, it's a very good point. A lot of organisations in the third sector do receive first contact, if you like, from a loved one or a carer or someone who is concerned about someone who may be unwell. So in the third sector, they're quite used to dealing with inquiries coming from carers in the initial cases.
Yeah, so just just to build on that as well, James. So I'll just remind us, as the CCG, we commissioned a first response service last year. So we're sort of in the sort of second year of the rollout, which you know, one of the really good things about this is that that's been brought forward because of COVID. That first response service will enable third parties to contact them. Obviously, there are going to be lots of issues around that as well, about sort of confidentiality, etc. But I think the real advantages to us commissioning that service is that it's there to support the wider family and support network, as well as it is the individual as well.
Yeah.
Yeah, thank you, Jo, and thanks, Liz, for looking into that, making sure that's integral. Those third-party elements. Sheila, you put a question on the chat. I'm going to ask you to do it verbally, but also can I just remind people that the valuable bits that contribute to our discussion, if we can keep them in the room rather than on the chat, then I think that just helps anyone who is then watching this at a later stage. Please, thank you.
Thanks, Paul. Liz, I wondered whether we are looking at quantifying potential mental health issues in our staff as a result of the pandemic. Are we including those staff members, recognising that occupational health services don't really deal with mental health issues, and those patients always get signposted back into the general mental health provision, including GPs, and I have some knowledge of that from my own work.
So, shall I start, Jo, and then you chip in? So through the IAP services, so the increased access to psychological therapies, that has now been opened up to all our health and social care staff across Devon. So it's not just for people that need the services. It is also for our staff and their health and well-being. And through that process, there will be some quantifying potential around understanding what their mental health issues are and supporting them. Jo, I don't know if you want to talk more about organisationally how that's being approached.
No, so I was just going to say what you were going to say, really, Liz, in terms of the extra things that our providers have put on to support staff, and that's whether that's in the CCG or within other providers. I was going to, I don't know whether Andrew wants to say anything particular about what we're doing in terms of staff groups, but it does feel like that additional support is there from our providers, which is really good. Obviously, we've got the occupational health offer, but as you say, Sheila, that often puts you back into services as well. So I think, don't know whether, not sure whether Andrew, you wanted to comment just in terms of anything additional.
Yeah, I mean, I think, Jo, I mean, we're obviously trying to keep very close to our staff, and we're making sure people are checking in with them on a regular basis. There is a national support line, as you know. DPT have offered support for our staff. But actually, the bit I think we probably need to do is see who's taking those sort of things up. And that's the bit I don't know that we're doing. So I think what I'll do is take that back. I've got an HR meeting this afternoon with the team just to see if there's more we should be doing.
Thank you. And then Sheila, I know you posed the question, but I'm sure you're very aware that for general practice, the LMC do provide a lot of that sort of pastoral support, and we are getting reports that the ask of that service is increasing, and so is reflecting the sort of things and the sort of concerns that you're raising. Penny, last point on this matter. I will ask but one, because I've just got one question I'd like to ask Liz at the end, please.
Thank you, Paul. I noted that when you started the presentation, Liz, you highlighted the point about developing the demand and capacity modelling. It seems to me it's going to be really important going forward that we do actually monitor the activity and where the demand is going, so that we can actually see the impacts and see which parts of the system are coming under pressure, and perhaps commend and bring something back in due course. That would be helpful.
Absolutely.
And Liz, I just guess the question is, there's lots of, we've got the plans, we've got our ambition here. Yeah. It's just asking what are the significant risks to delivering or managing the increased mental health concerns within the community that we will face, that we need to be aware of.
So I mean, overall, I guess the initial risks are not having enough capacity. So we've got risks because we don't know, we're making some assumptions around what the demands will look like. So the risks there will be overall, will we be able to meet the demands in capacity demands locally? And we need to make sure we've got robust contingencies in place to look further out. We also need to make sure that we're working efficiently across our system, across Devon, across both providers, with our community mental health teams, with our home treatment teams, to make sure we are utilising them as effectively as possible. And as James says, we've got to really make those connections with the voluntary sector. We know they can really help support early intervention to prevent people having to come into our services. So I guess the risks are there's a lot to do. And we need to make sure we've got strong connections to take that forward. But I think we've got a really good, robust basis to take that forward, particularly with the work that's strengthened across our partnership working over the last 10 weeks across the system.
Yeah, and just to add to that, Liz, as well, I mean, we know how important early intervention is if people are presenting for the first time with mental health challenges. And I think providing we can meet the need, especially of the low-level sort of needs that people have at this stage, then we prevent their health deteriorating and then impacting on secondary services and more so on primary care as well at a later stage.
Great. Well, thank you both, not just for the presentation, but actually all the work that underlies getting to the point of that presentation. And thank you. We'll move on now. Just for the record, Joe Turl and David Greenwell have to leave us now. David, sorry, he's just realised he has to go. You're on the overview and scrutiny at Torbay with Torbay Council. So thank you both. And also Philip has the regular webinar with care homes that he had to go to earlier. So we have people leaving, but for very good reason. Thank you. So item 6.3, Sarah, is the discharge update.
Thank you, Chair. So that was such an impressive session. I want to try and make discharge just as interesting. And this paper shines the spotlight on the work of the discharge cell. It was established as a result of the national guidance that was published in March, and Simon asked that we establish the cell, which still operates today over 7 days of the working week. Its value has been about bringing all the localities to work together, so there's a consistency of approach, and has allowed them to forge some really strong relationships with providers and to have a single version of the truth in terms of the data that they are mutually looking at and considering, so that they can support trusts and come forward with expertise, particularly drawn from colleagues in continuing healthcare, expertise around end-of-life services, where there are particular blockages. So it's, I think, been of mutual benefit to the system. And over the period March through to May, we've held an average position of 65% bed occupancy. That, since the end of May, has been severely challenged, but in the period that I'm speaking to, we were able to comply with the local standard on that. Importantly, as Simon referenced earlier, we've now moved our work to focus on locality capacity plans for out-of-hospital care, so that we can know and understand with much greater precision what is needed for both business as usual and surge planning. We're doing that on a phased basis, and we've just got our phase 1 plans in from each locality, and we're sharing learning all the time. So I'm going to pause there and take any questions, because this paper is essentially to share with you that work and the progress that has been made to date, and it will be ongoing.
Sarah, thank you very, very much for that. I think Simon Kerr, your hand was first to go up.
Yeah, thanks, Sarah. Can you just clarify what what notice you've taken of the potential impact of those discharges on other organisations out of secondary care, the quality of those discharges, and the readmission rate that might occur from discharging people perhaps sooner than they might have been discharged before.
So we've used the national guidance as the steer for our work, which was explicitly about maintaining flow and appropriateness of discharge against defined need for individual patients. So I think your first question was, how have we worked with the providers to make sure we are working in line with patient need? Is that the first element of your question?
We've been through this type of issue before with reduction in beds in the eastern locality. And we had to be very cognizant of the impact on other providers outside of secondary care, so primary care and the voluntary sector and other people that support people once discharged home. That's my first point. The second point was, what about the quality of those discharges? Have we taken any view on how well put together those discharges are? And the third point was, what have we done to look at the readmission rate of some of those people who might have been discharged early and then readmitted back to the hospital because the discharge didn't work?
Right, so working through each one of those. In terms of other providers, we always are mindful of making sure that, for example, as I've mentioned, we've drawn in continuing care colleagues when we've wanted to gain particular access to care homes with sometimes specialist support around mental health. So we've worked, I think, quite carefully with providers to make sure we balance the requirements of those providers. In terms of the quality of the discharges, we haven't got clinical colleagues on the discharge cell. We are supporting the trust in their clinical decision making. So I think it would be fair to say we haven't reviewed or looked at the quality of discharge. And then your last point was, remind me, I'm sorry, I've just missed it down.
Sort of the same thing. Did the discharge work, or were there quite a lot of readmissions because the discharge wasn't effective?
Yes, so we're starting to look as part of the capacity planning work, which is both looking at discharges and admissions into the system. We're starting now to focus on that.
Thanks. I'm going to bring Gaynor in because she's got a question and also may be able to give us some insight as experience in some of that other organisation activity, the people who would be caring for these people upon discharge. Gaynor.
Yes, I think the community services have responded very well in working with the acute trusts with regards to sort of helping with discharge, so the discharge to assess model. My concern is that we have stepped up therapy over 7-day working by utilising therapists that were covering the outpatient services before, which has obviously been stepped down. We're not commissioned for 7-day services for therapy staff in rehab in the community, and is that going to be part of the planning, or can that be part of the planning really? We have got the therapists covering the 7-day working up to September, but from beyond that we will have to be looking at stepping down those 7-day services if those therapists go back to their business as usual roles.
Chair, may I respond to that? So the policy, the national policy for 7-day working and discharge applies to obviously providers and commissioners. So clearly all trusts are currently looking at this, and it's part of the work on our capacity planning to support 7-day working where that's practical and meaningful and there's good access. So I would be expecting the trust that you refer to very much have this on their agenda.
Thank you. And just on this issue, can I just ask? So one of the things that we know is that we have a sort of a green to go list, which is those patients who shouldn't be in hospital because they're fit to go home. But often it's the logistical things that stop them, whether that be the package needing the support needed, the placement, or even the means to get them home. And my sense from your paper is actually that's where a lot of the focus is actually unblocking those things that stop the best care that we want from actually happening, and therefore lead to people being in hospital when the professional decision has already been made that that's not the best place for them. Is that right?
Yes, yes, yes.
Sorry, Paul. Can I just come back? Because I just heard from. I know you probably didn't mean this, Gaynor, but it's always something that puts ice in my veins when somebody says we're not commissioned to do that. And what I'd say back to that is the acute trusts are commissioned to make sure there is timely discharge, and given that North, East and South are all vertically integrated trusts, the money is there. It's a service provider decision about whether 7-day therapy support is in place. So I would urge us to use the right language, but I'm more than happy to talk to Suzanne and colleagues about what's getting in the way, and it's probably workforce as opposed to money, isn't it, in terms of providing a 7-day service?
Yeah,
Okay.
absolutely. Yeah, workforce is an issue.
Okay, thanks very much, Simon. Judy, sorry, I've interrupted your opportunity several times now, but it's over to you.
Thank you. It's fine. It's a really interesting discussion. And this is a classic example of what happens when you bring really focused senior attention to an issue that drags on and comes back again and again every time we lose focus on it in the NHS, this bed blocking, this lack of discharge. I wanted to encourage two things. One is that we absolutely keep this level of senior intervention, maybe not every day and at the COVID level, but that kind of focus and the bringing everyone together. But the other issue, of course, and it links to what Simon said really, is the better system is to stop people going in the first place. And whether this group can be looking at that, because when somebody gets admitted, all of those social structures that were keeping them at home, mostly well managed, can break down and then become much more complicated to put back in place. And maybe some of the revolving door cases, the one Simon talked about, coming out perhaps before they were ready or the system was ready and then going back in again. Maybe we could have some statistics on that. I apologize if they're in here and I've missed them. But that is also a good way of focusing on the let's prevent unnecessary admissions side of the picture as well.
May I respond to Judy's point? Because that's just very recently been picked up as a focused piece of work, which Sonia's leading at the moment. So it hasn't fallen within the auspices of the discharge piece because our focus has been on the flow out. But what you describe is absolutely now critical and work has commenced on it. So we can definitely, I'm sure, respond.
Thank you. And just Judy on that point, and just to remind people, and when we were together earlier as a governing body, and so members of the public, I apologise you weren't part of the discussion, but one of the things that our staff have fed back to us is the executive focus that we've seen in COVID has been hugely helpful, and I think this is a good illustration of what can be achieved through that focus and how we need to try and hang on to that. So a really good illustration of that in practice. Thanks, Sarah. Graham.
Thank you, and thank you, Sarah, for your report. My question perhaps is for you, but also for Simon and John. I was really attracted by what you talked about in there being a single version of the truth. And in my wilder dreams, I think about a single version of the truth in regards to finance, performance, and lots of statistics. And I just wonder, over time, is there any chance of us putting a team together from commissioners and providers who provide one set of finance figures that goes to all the boards and this governing body, and similarly with performance, please?
Yes.
Yes.
So I'm sure there is, Graham. I mean, again, it's another area where we are wasting time. because we're having to check other people's work, and then there's this dance that that's not the right figures, etc., etc. So absolutely is an aspiration. It requires the willingness of partners, but who knows, the integrated care system might actually make this evolve. So yes, we'll carry on and try our best.
Thank you, Simon. Penny, I'm going to give you the last comment on this one.
So mine was only to back up Simon's comments to say that's the aspiration of population health management, that we all agree a single set of data and we all work together on that. That's one of its ambitions.
Great. Well, thank you. And thank you, Sarah. And if you could thank your team that I know have put a huge amount of effort into this 7 days a week to try and stay on top of this and make this work. So if you can pass governing bodies thanks for that, please, that would be great.
Oh, thank you.
Item 6.4 is recovery, transformation and service change. Simon, this does say paper to follow, but I understand this is going to be a verbal because I know members of the governing body have seen some examples of the sort of work that's going on, but it's not here as an official paper purely because they are internal examples rather than fully developed plans. But you were just going to give us an overview of that work.
Yeah, sorry, I was having trouble with my headphones. I'm really glad I bought those a couple of days ago to try to ease my comfort, so they don't work all the time. Yeah, so I just wanted to say to governing body about the process. So there are 3 elements to the recovery work that John Finn and Alison Wilkinson are leading. So there's some work with our main providers, so our 6 providers, our 2 mental health providers and our 4 acutes, where we meet as a system once every couple of weeks to go through what they're looking to stand up, what are the restraints they've got at the moment or constraints they've got at the moment, and agree almost on a block basis what they're about to stand up. There's a set of individual conversations with some of our smaller providers, and that's an individual basis. We don't bring them together in the system. We have that separate contract conversation around how are we going to stand up and stand up services, make sure we can still stick to infection control measures, etc. Is there a digital option, for example? And then the third bit is the longer term, what I would call phase 3. We're still waiting for Simon Stevens' phase 3 letter, but how does that accord with our long-term plan? Are there some changes we need to make? What are the new national priorities? And indeed, what are our new local priorities? So there are 3 elements to it. We had to do a return or a weekly return to region on how that's going. I saw the latest spreadsheet I think it was last Friday, that's got about 300 entries on it. So that hence I've not brought that to you for consideration. It's too detailed for us to work through. But our process goes to the executive team once a week. So John and Alison come and present to us every Friday for us to go through that. There is good clinical involvement. So Claire Hooper is leading on all of the elective work, and we also have input on urgent care and on mental health and other specialties. So I just wanted to highlight that. More than happy to ask John to write up a summary document and send that round and perhaps present at the closure of phase 2. So we've got to submit to region again next week our formal response to phase 2, and I'll bring that in a formal report next time. Okay.
Thanks very much, Simon. I think because it's a work in progress and we've not got the detail in front of us, let's do the questions when we've got a bit more of the detail. As you say, if you bring that next time, that will be hugely helpful. Thank you very much. John, finance report.
Thank you, Chair. So I'm just thinking with Graham's words in my ears about the truth that this is the only version of the truth that we'll have today on finance. But the report is there for all to read. But there are a couple of things that I felt it necessary to stress this time. So we often hear the words at the moment about unprecedented times, but these really are unprecedented times from a finance point of view, and we're still working in the environment where the commitment from government is that all costs reasonably incurred will be reimbursed. So that's the key part of the framework that we need to hold on to. So as long as our costs are reasonably incurred, then for the period of 4 months at the moment that the framework has been applied to, then those costs will be reimbursed. In order to give us some semblance of assessing what's reasonable and getting some assurance around that those costs will be reimbursed to us, we have been set an indicative plan by NHS England, and it's against that plan that the numbers in the report are reported against. So just to re-emphasise that again, it's reporting against a centrally set plan by NHS England. It is not reporting against the operational plan which we approved as a governing body prior to entering the emergency response period. And that does make interpretation just a little bit more complicated, because when we look at a variance, it's not necessarily particularly informative. So what I've tried to do, and we'll talk about it a little bit more, is to go back to what are we actually spending to try and get a view about where all this is going. So it's an indicative plan set by NHS England against which we are expected to report for the first 4 months of the year. What we have also been very careful with is to ensure that we are recording the additional costs incurred directly in response to the COVID incident response. And just to tie a couple of things together that we've already spoken about at the meeting, the faster hospital discharge scheme, which Sarah presented on, I think that's worked incredibly well, and we have been working well with operational colleagues across the NHS and social care. That's also been working very well from a finance point of view. So with our colleagues in the 3 local authorities, we've been working to ensure that not only are the right services in place and the right capacity commissioned, but we're clear about what the cost of that is, such that we can put forward the appropriate reimbursements for those costs. And just for a bit of context, in the first 2 months of the year, as is included in the report, we'll have spent about £3.6 million on supporting that faster hospital discharge initiative. Another reasonably significant cost that we've incurred directly in response to COVID, again, it's been referenced several times during the meeting, but in getting some support into the care home sector. So that's been going in not only through advice and guidance and in some cases supply of the necessary PPE, but also in recognising an increase to the fee rate that's paid by both local authorities and by the NHS for care in the care home sector to try and provide at least some financial stability into there. And that's been about 1.8 million for the first 2 months of the year, as again is referenced in the report. In terms of detail in the report, I won't look at it now, but very happy to pick up any questions. Probably the most useful table, I think, if people want to look at it now or reference it from the papers afterwards, is the summary table on page 74, section 3 of the report, which just breaks down our expenditure and shows very clearly what we've spent directly on the COVID response, which is in total £10.6 million for the first 2 months of the year, but also shows what our expenditure against the plan centrally set by NHS England for non-COVID related services will be. And there's an explanation of the main reasons for variance against that also included within the report. Last couple of things to say in terms of introductory remarks. From a governing body perspective, we are required to take a view on risk. I mean, I would say the biggest risk at the moment is uncertainty, and that uncertainty is about what happens beyond the first 4 months and the emergency financial framework that we currently have. We don't know the answer to that yet, although obviously with that time fast approaching, it is a very active conversation between NHS, EI, Central and government about what comes after that. In preparation for that, however, and to give us some sense of what the risk profile would look like, I mentioned at the beginning that we've been doing a little bit of work on what's the rate of expenditure that we've observed over the first couple of months. So if you ignore, which is a big assumption in itself, but if you ignore the amount of additional expenditure we've incurred directly in response to the COVID emergency period, the 10 million that I was talking about previously, if you extrapolated the run rate that we've experienced on those non-COVID services, so the expenditure that we're making on non-COVID related services, that would indicate that we were on a course, if nothing else changed, to spend in the region of about £80 million higher than our allocation that was made to us. And that figure compares to the plan that we set ourselves of £43 million of deficit. So it's running higher than we might have expected. I could immediately explain most of that because we know that we were planning to deliver a number of savings and efficiencies which we will simply not have been able to do during the COVID response period. But there is still an element to which our expenditure rate is running a little bit faster than we expected, and that's particularly evident in primary care prescribing. So we're doing a little bit more work about understanding exactly if there is anything unusual in the first 2 months of the year's expenditure that is not directly linked to COVID, but may well be influenced by the COVID response. And as we start to exit the emergency period, on the one hand, we'll know what the new financial framework is, but on the other hand, we'll know what our forecast total expenditure is likely to be, so we can start to make a similar comparison to that we would have been used to in previous governing bodies. That's probably all I want to say by way of introduction, but very happy to pick up any questions either on the detail of the report or that sort of look towards the future.
Thanks very much, John. Can I just pick up very quickly on that last point? So during the last few weeks, we've stood down quite a substantial number of non-COVID related pieces of activity. Has that impacted in our expenditure? And if so, then the concern would be that 80 million reflects a system that is not running at the sort of level that we need it to run going forward, and then that would heighten the concern.
Yes, so the answer to that is mixed in some way, Paul. So some of the services that will have been stood down, particularly in our main NHS providers, from our CCG perspective, that doesn't make a difference to the rate at which we're spending because that money is still flowing through into those providers. In some cases, however, where a service has been stood down, we will have ceased paying for it for that period as well. So that is a slightly mixed picture. Another feature that we just need to work through is the best example I can think of is the independent sector, where people will probably be aware the independent sector capacity was nationally commissioned for the period of the COVID response, and we have actually had money taken off us, if you like, to pay for the fact that that's been commissioned centrally. So there's quite a lot of swings and roundabouts going on in that underlying run rate, which is why, as I've mentioned, what we want to do is to just examine that a bit more carefully to see what else is going on there that's not identified directly as a COVID related cost, but may well be being influenced by the fact that we're in the response period.
Okay, John, thanks. That's really useful. Nick Ball.
Thank you, Chair. John, what is the kind of the level of political pressure that the CCG is going to come under from NHS England if we are missing the underlying deficit position? So you talked about us overspending to the tune of 80 million when we said we're going to be overspending to the tune of 40 million. So if we're 40 million off the underlying plan, are we going to be as severely on the naughty step as all other years, or is it kind of an all bets are off because of COVID year? Because it doesn't feel like a very good place to be in at the moment.
Yeah, so I certainly wouldn't expect it to be an all bets are off, Nick. But I think the important thing for now is just to recognise where we are and the further work we need to do to understand what our rate of expenditure looks like, ahead of knowing what the framework is going to be like for the rest of the year. So we know that all costs will be covered for the first 4 months of the year anyway. I think it's impossible to say at the moment what the rest of the year will look like, but it is important that we're getting ready for that. So the bit that we can answer and the bit that we're in control of is the expenditure side. What we don't quite know is what the expectation is that we set.
Okay, and do we know how we are placed compared to other local health economies in terms of our financial position?
Not at this stage, no. Right, I don't know that.
That's fair enough. All right.
Okay. So it does sound, John, the level of complexity in this and the numerous variables are going to take time for us to have any of that sort of degree of certainty. But it's very helpful to have in the table there, the details that we do have. Judy. Judy first.
Thank you, and thank you, John, for helping us understand where we're up to. And I'm glad you're doing some more work on the prescribing one, because that looks quite challenging. A question and a comment. My question relates to what you say about the Nightingale ward, which I'm just trying to find. It's in section 4. Expenditure on the Nightingale Hospital has largely come to an end for the CCG now that the facility is under the control of the Royal Devon and Exeter Trust. My understanding is that we commission services from the Trust and they expect us to pay for them. And therefore, in a sense, it is still a financial issue for us, and one where control has been handed over to someone else, although I know there's really good team working. So I was worried about that statement, because actually that does need careful management, even if it comes out of the COVID budgets. But what's really interesting to me now is you saying that government are now starting to top slice our budgets for pay for things they said they would pay for centrally, i.e. the independent sector. And I think perhaps we need some urgent work culturally. So I was a bit surprised. I thought we would be spending less of our normal money because everything's going on COVID and we're getting extra COVID money. And I bet there's an awful lot of people who are thinking like that too. So getting the message out that just our ordinary expenditure is overspending now already, I think is a very important point to get out to the trusts, to our staff, to anyone, that we need to start tackling this. In the primary care committee the other day, we were told that the primary care budget has been set at an overspend, and actually asked Ben to come back to us next month with more information, because it didn't seem right to be planning to overspend in a year when we're supposed to be not. And so I think there may be this kind of false 2 months or 4 months, oh yes, it'll be covered, the government are covering, maybe leading to a false sense of security around the finances. And we really should be taking action very early in the year, not to overspend on our regular budget.
Yeah, so a couple of things on that. Really, specifically on the Nightingale, your analysis is right there. It's a slight quirk that during the setup period, the costs associated with setup of Nightingale were flowing through the CCG, or were being incurred by and charged to the CCG. Now that it's getting close to being ready to be commissioned, the operational management's handed over to the RD&E, so the ongoing cost of that will be recovered by the RD&E as part of their direct relationship with NHS EI for that. So that will cease to flow through us. On the more general point, I mean, I think it's certainly been the case, and quite rightly so, that the priority has been to ensure that that money is not an obstacle to making sure that we're making the right service response to the crisis that we're in. And we've always understood, haven't we, that at a particular point in time, then money will return as a bit of a constraint. I guess the issue for us as a governing body and a wider system is how we work with our services to ensure that constraint begins to be recognised again, but perhaps isn't front and centre, because actually that's not necessarily the best way to get things done. So it certainly feels to me as if we're still in a period where we're working out what the new normal will look like, and there will be some implications on costs for that as we start to exit the emergency response period. So this issue about getting back to what's our underlying expenditure rate looking like for the remainder of this financial year and even beyond that is the real key for me. And until we understand that a little bit better, I think it's hard to say what some of our responses might be, if indeed it is the case that we're continuing to overspend.
Paul, can I just comment? I mean, I hear what you say about, absolutely, of course, the COVID response is priority, but we mustn't be slow to start talking about this, and we mustn't do 2-3 months worth of background work until we have all the stuff, because we are emerging. You know, things are going back to normal now. We know there will be other peaks. We know that there's lots of practice that's having to be done differently because of PPE and all those kind of things. But what we know is that the government does not have a bottomless pit, and will start getting quite robust about expenditure issues because of the sheer pressure on them for all the places that are coming to them for money. So I would urge that, without being alarmist and without being undermining of the support on COVID and its longer term consequences, like the mental health ones we were talking about, we must start addressing financial balance issues again sooner rather than later, because any of the action is going to take a while to get done.
Okay. Thank you, Judy. There's 2 more, and then we will move on. So let's have Nick Kennedy and then Simon Kerr, and then John can respond to both of those. Nick.
Thank you, John. Sort of following up on what Judy was saying, you've stated that NHS Devon CCG is to report to governing bodies a break-even position, but they will be reviewing things, and where they deem expenditure to be reasonable, a retrospective allocation will be issued. Have we got any confidence that what the system has been spending will be deemed as reasonable, and how much of a risk there is that we're going to find that actually they say we're not funding this and there's an even bigger deficit? And on top of that, do we have any way of controlling our COVID expenditure, or looking at it very carefully or much more critically now as to whether it would be deemed reasonable?
Okay. Let's take Simon's comment, and then John, if you can tackle both of those.
Yep.
Okay, me. Yeah, it was just really to pick up on the prescribing issue. I can see actually there's an explanation in your report, John, as to why you're predicting quite an overspend in primary care prescribing. But if I look at the detail, why really have we got a 3 million underachievement already in month 4 on the quit plan? We've all been here. We've still got our pharmacists working. Why couldn't we still be working on the quit plan for pharmacy, for example? And picking up Judy's point, there are still things that we could be doing, surely, even though we're in the middle of a COVID crisis.
So, John, do you want to come on for this? Simon, you might need to step in Joe's absence around prescribing, I guess. But John first.
Yeah. So on the controls point, really. So our confidence about that being reimbursed is really linked to the controls that we've had around checking those commitments before they're made. So we changed the financial control arrangements a little bit so that we were able to be as responsive as possible in the emergency response period, but we've still had good governance around those new spending decisions as they've been made. So our confidence around reimbursement comes from those input controls, really. On the QIP and specifically on prescribing, I mean, Simon may want to add. I mean, it is certainly the case that that we stood down a number of our so-called non-essential activities to provide a little bit of extra resource. But I think it is not necessarily just about the efforts of our team. It's about the ability for the people that you're working with, often on frontline services, to be able to respond and work with you on that, where we've found that some of those schemes just won't have been progressing. It's probably not necessarily the best example to use prescribing, but certainly in some of the other clinical services that'll be the case. I don't know if Simon wants to add.
Yeah, so only to build upon John, really. So I think you're right. It's not, Simon, I think your comment that you've all still been here and working, I think that's right. But some of our GP practices, we felt it was more appropriate to be able to give them some space to deal with what we thought was going to be quite a difficult peak that we had. We've certainly redeployed a number of our pharmacists and some of our leads that would have been concentrating on prescribing savings have actually been redeployed to our acute hospital. So I know we've got, I can't remember, it's 3 or 4 of our pharmacists working in UHP, supporting their effort within the hospital. So it's right and proper now. Because we haven't had a peak, and actually, I'm touching wood, things are quite quiet, aren't they, that we start to get back to that. I've just written John a quick note, really, that if we've got block contracts with our main providers, CHC, there are no assessments. So what I can say is that our CHC budget is about £140,000 a week less than it was going into COVID, but that's because no CHC assessments are being undertaken, and we've had, I think it was 104 last time I looked, 104 deaths, but no patients coming in to replace those, and that would be about average, by the way. So it's not that's not something that we should have been concerned about in terms of numbers. Obviously, for the families, we should be. The running costs we've kept under a really tight rein. So the things that we were looking to do and change were really around referrals and the impact that would have on our acute providers or the independent sector. And that's been completely out with our gift now that we've moved to block contracts, and certainly the independent sector being under a national contract. So I wouldn't want people to think that we'd completely forgotten about it. We've absolutely reprioritised the pandemic response, and it's absolutely right and proper for us to start to stand that up now, because if anything, I'd like to take the opportunity through this pandemic to try to, as much as possible, get our finances back under control. That may or may not be possible. So you're right in all your questions, but that's just why we weren't concentrating as much on prescribing, Simon.
Thank you, Simon. Can I just add a general comment that we're going to have lots of conversations in the coming months about our experience during COVID, but let's just make sure we remember the place we were in March, where we were told we had to prepare for an overwhelming demand on our whole system, and we didn't know whether that would be a reality or not. And so a lot of the actions we took then were very much in that context. And I think it's important that we remember that. The flip side is, now that we know that things are different, we must get back on track with a lot of these things, as everyone's articulated. But let's keep remembering the context with which we operated at the time. I think that's really helpful. Otherwise, we will be continually overcritical of ourselves and of others. Okay, let's move on to 7.2, to the Performance and Quality Report. That is Sonia and Darren, I think, is joining you, because Philip is on with the care home webinar, I think.
It's Sarah, Chairman.
Sorry, apologies, Sarah. Sorry. And that's £1.
Okay, I owe £1, apologies. So Darren and I will do this as a double act, and if I may, I'll go first with the performance pieces. Clearly, this paper builds on the last item where we've just talked about the impact of COVID in relation to finances. This one, I think, is incredibly significant to us in terms of setting out and quantifying the impact on clinical activity over the period. And as you see, it details the impact in the last month of 2019-20 and in the first period of the year that we're in, 2021. So the detail of the paper obviously reveals where improvement was made on some targets, such as, for example, the A&E waiting times, but more driven by the fact of the public not coming forward. But by comparison, the deterioration in our 52-week waiting time and diagnostics. Throughout that period in March, we maintained access to urgent cancer, diagnostics and urgent care in general, but clearly the deteriorations there are immensely significant. As we move forward into the month of April, the first month of the new year, the national guidance required us to maintain oversight of the constitutional standards, but to have no hands-on performance management role through to the end of July. And so on that basis, you have the preliminary unvalidated data that has been made available to us, which reaffirms the deterioration again in the 52 weeks and the A&E piece. We now are keeping one eye on what will happen from the 1st of August going forward. And as has been mentioned, we're awaiting national policy. To preempt that, we've started having conversations with all our providers about their expectations of performance going forward and how we might make it a more meaningful activity with a view to actually attaining and sustaining delivery. I've nearly completed those conversations, but it's trying to reset our approach in a more positive way. I'll hand over now to Darren for the quality and safety element of the paper.
Thanks, Sarah. So I think probably, coming into this relatively fresh with fresh eyes, there's a few elements that I'd like to bring governing bodies sort of attention to, both in terms of the previous month and then in terms of the last month, April, and how we move forward. So I think there is some significant learning that we can take forward from a quality perspective over the last 12 months. So I think there have been some real good areas of practice, particularly in terms of where we've been working much more collaboratively with providers. I think particularly the ED focus surveillance in terms of quality visits into ED were received really well from a system point of view, but actually identify good learning and good practice that we can then take and grow across the system. So those are some of the areas that I would suggest that we really want to take learning going into this year, particularly as we move into redesign and recovery. I think some of the other challenges that we've seen in sort of the latter months of the last financial year, particularly around quality and safety around diagnostics, I think for me that is a big challenge, particularly linked to Sarah's identification there around the performance and actually how we can give governing bodies assurance around the harm and particularly the quality as our diagnostic rates continue to increase. there is definitely some more work to be done, as we've already heard, and we've spent a lot of time today talking about the mental health elements, but we need to triangulate the learning that we've seen and some of the themes that I've pulled through the papers going forward. I think one of the other areas in terms of some real foresight was our investment in healthcare acquired infections, and particularly the investment in infection prevention and control. As commissioners, that has really paid dividends as we've moved into the pandemic, and particularly in terms of the latter part of 2019, 2020. And into this particular year. And I think that has bared real reflections in terms of the outputs that we've seen and the collaboration that we've seen in terms of the care homes. That's definitely been a real area again. And I know Simon alluded earlier to the cell approach, and I think that again that's an area that we do need to look at going forward, particularly in terms of whether that's a cell or whether that's a hub. But actually, what we've seen from a care home perspective, it has been very system driven. Very collaborative, so all parts of the system, both in terms of health and social care and the CQC, etc., all coming together with one collective aim. And the latest research suggests that actually, despite having one of the largest number of care homes in the country, around about 500 care homes, our mortality was one of the lowest in the country as well, so significantly positive from that point of view. I think going forward and looking from particularly the impact in April, is that we do need to look at how we work with our providers a different way to really get a stronger sense of quality, and not just focusing on some of the safety metrics, to truly get under the surface and understand the quality. And that will have to change slightly, as we've seen, as Sarah's alluded to, in terms of performance with long waits on 52 weeks, etc. And I think the final thing I'll just draw the governing body's attention to is there is a comment in the paper around safeguarding, and I think one of the things, definitely that we have seen as a consequence, particularly of lockdown, that we are seeing significant impacts in terms of safeguarding, particularly against domestic abuse, and some of the wider elements in terms of child and adolescent harm. So that's particularly an area that we do need to focus on in terms of how we report and assure that back to governing body. And I will open that to questions.
Thanks very much, both Sarah and Darren. I'm going to go first to Graham.
Thank you, Paul. I guess I want to try and link the last report to this one. I was very keen that John brought forward his report, as disappointing as it was in terms of the news about us being on course to overspend by 80 million, higher than the allocation compared to the 43 million deficit, which had been proposed originally. And if we remember, John was very clear that that figure was based on extrapolating non-COVID services. So we're looking at a big overspend on non-COVID services. And yet, when we look at this report, we see that the performance, other than in A&E, is deteriorating. Diagnostic waiting times, RTT, cancer waiting times, and so on. So I guess my worry would be, if our performance had not been deteriorating and we'd been actually having a lot more activity, what would that have done to the financial numbers?
I suppose, well, it's John, it's you sort of link the two together. It's similar to what you discussed earlier, but
yeah, so on that one particularly, Paul, it wouldn't have it wouldn't have made them any different, because what's going on there, I think, is just a redeployment of staff within the organisations that we commission services from, certainly the big NHS organisations. So it won't have made any difference to our financial performance, because that money is just flowing from one bit of the NHS to the other. It's how those teams are being deployed and the services that they're delivering that will have changed. So financially, it wouldn't have impacted on us.
So this will come through, John, in the system performance figures, will it?
Indeed, yeah.
Okay. Thank you. Sarah, can I ask you a question? I know you don't have the details here in front of you as part of this board packs, but if you could give us a sense, I know that we deteriorated in our performance, particularly around non-emergency activity when COVID hit. one gets a sense that that would be a national picture with the number of services that were stepped down nationally due to NHS direction and preparation for COVID. So do you get a sense whether our deterioration is proportionate to what has been seen elsewhere, or have we fared differently?
So we've started to look at the national comparisons, and those preliminary analyses suggest that in general Devon has done better than the national position. There's been some variation across our providers, but overall, by comparison nationally, the impact has been less than has been seen elsewhere.
Okay, thank you. That's very helpful. And I guess I'm seeing if there are other questions, so I'll ask another one if I may. The targets that are set, if nationally there's been a deterioration, do you get any sense that the targets that NHS England will set, certainly for the remainder of this year, are they likely to remain at that sort of level, and therefore our expectation to play the catch up and get on top of referrals, or do we get any sense that there may be any shift in those for what we should be aiming for as a system?
My sense is really based on talking with colleagues in performance networks, and I think we were expecting national guidance this week. There has been a delay, and that perhaps suggests that consideration's been given more carefully to what is truly achievable in the remainder of this year. Because in large part, reverting back to the prescribed standards are not going to allow us as a system to move forward in a meaningful way. So I hope I'm reflecting what I'm hearing. That's going to be borne out in the guidance that we now expect is going to be delayed until early July.
Thank you. That's really helpful. I suspect it will not diminish massively the amount of work we still have to do, but we might feel that the end point is slightly more achievable than otherwise. So thank you very much. I can't see any more people wanting to raise any questions or comments. So thank you both Sarah and Darren for bringing that to our attention. So on to item 8, 8.1 and 2. Ginny, do you want to take us through 8.1, and then we may need to pause for some questions around that before proceeding?
Okay, so you're being presented here with a draft terms of reference for a commissioning committee. These were developed on the back of the last development session that we had as a governing body before COVID, and they are designed to respond to a number of issues that came up as part of that development session. The first one is making sure that we have really clear governing body oversight of the decisions that are made on commissioning services. At the moment, the way that we are set up and our decision making structure within the CCG is such that those decisions can be made by a number of executives, another number of different groups, and we don't have anywhere where that's all pulled together that reports directly into governing body. So that was felt to be one of the key issues that we needed to address. The second was making sure that all our commissioning decisions are made in a really robust way, and that's again, so things are done slightly different ways in slightly different parts of the CCG and relating to different services, and this all links back to what Simon was talking about earlier on about the commissioning cycle and making sure that all the decisions are made with evidence of good practice and good data about what's needed in terms of health in the patch at the moment. So it's making sure that everything is done as well as we can. And the third one is making sure that we have good clinical input into all our commissioning decisions, and that means making sure that that clinical input happens at the development stage and is not something that just happens at a committee or at governing body, so that we make sure that when those decisions come to the commissioning committee to be made, they've already had the appropriate clinical input from the people that are best placed to do that. So the proposal is that we establish this commissioning committee, which would feed into governing body. Very happy to take any questions.
Thank you. And just to note that we as governing body are being asked to approve the establishment of the committee based on the terms of reference that we have in front of us. Charlotte first.
Hi, thanks. I wondered if any thought had been given to a non-executive lay member being part of the committee structure, as in with other committees, and bringing that kind of impartiality and different voice and perspective to the committee. So I mean, I would be keen to see that. And the other point was one of the audit recommendations, I think, was around strengthening equality and diversity. And I wondered if that was maybe as part of the kind of remit of the committee, was to look at how that could be kind of drawn into the commissioning cycle or strengthened as part of their remit.
So do you want me to
answer
that? So when we discussed it, Charlotte, we did consider that, but we quickly ruled that out because it's not an assurance committee. This is about decision making, and we felt it was more appropriate to allow governing body to assure themselves directly for the big commissioning decisions. So your second question about equality and was that about health inequalities or equality and diversity in our?
Well, it's about both because it's in the audit recommendations, but I suppose it's strengthening the use. There's obviously in the recommendations around the paper, it talks about this kind of remit. And I wonder if there's some strengthening to do around using the equalities data as what, incorporated into population health as part of that group, but it doesn't make explicit reference. And I think perhaps it could do, given the recommendation in the audit and also the kind of remit of the committee.
Yeah, okay, I think that's a good challenge, and we'll look to strengthen that.
Simon, can I just ask, it might be helpful, because I know you and I have discussed about this, that the decision-making powers that currently exist outside non-executive governance compared to the decision-making powers that would sit within this new committee. I think it's quite helpful to understand what, if anything, would change.
Yeah, so we talked about this, didn't we, Paul? That so obviously the decisions are currently made in line with the scheme of delegation, but through the executive committee. So with John and myself both present, that gives quite a high value and delegated authority. So the reason I removed the role of accountable officer from the commissioning committee was to make sure that none of the big decisions were made there without proper reference to the governing body. So that was the differential we wanted to make. Plus, as Ginny said earlier, really demonstrating proper clinical support and influence over the decision making.
Thanks. Thank you, Simon. Nick Ball.
So there are a couple of things I would say that may help Charlotte. So there is a very, very new paper out from NHS England about the role of audit committees. I only saw it 48 hours ago myself, and our audit committee hasn't had a chance to think about the implications for us. But it puts a increased emphasis on the role of the audit committee in looking at the governance of other committees, and talks about other committees being required to report to the audit committee in terms of the governance around them. So that, for my money, makes it more acceptable for the commissioning committee to not have a non-exec on it. But the bit of logic I couldn't understand was, why have you chosen to have a non-GB person on the chairing that committee? And just in terms of making the natural link to the GB, that didn't make so much sense to me.
Yeah, so Nick, we discussed this with our governing body clinical lead. So it was really about some succession planning to try to make sure that we are having the next level of our clinical leaders coming forward and being able to experience chairing and being involved in a very senior way in terms of our decision-making process. I think we could be open to reviewing that if, again, as the audit committee thinks that's a better process. But I wondered, and this, my decision-making around this or rationale was around some of our clinical colleagues may feel slightly reticent if one of our very experienced governing body GPs chairs the meeting. That's all it was, Nick. There was nothing sort of hidden to it.
So would the chair be invited to attend every governing body meeting to report on the activities of the committee then?
They could send a report, couldn't they?
So Simon, just for helpful, who would be the common members between this committee and the governing body who would then be able to provide further explanation around a report when it comes?
So a GP clinical representative, or the Director of Finance, Director of Nursing, 2 Directors of Commissioning, Chief Operating Officer and the Secondary Care Independent Clinician. So quite a lot.
Yeah.
Okay.
Okay, can I just think about that? I'll come back to you, Simon. Yeah.
Of course.
Okay. Thanks.
Any other questions?
Sorry, I should have said, Paul, that also with any governing body subcommittees, as long as people seek or out of courtesy speak to the chair of the committee beforehand, they're obviously allowed to and would be welcome to attend, but not as members.
Yeah.
Okay. So while Nick is considering that, we've got no further questions. So can I break this down into 2 parts? So the first part is the formation of the commissioning committee with the terms of reference that we have, but the chairmanship or the chairing of that committee being something that is yet to be decided. But are we are we in a position to agree that its formation, given the additional element that Charlotte mentioned to be included within the terms of reference? Again, I'm going to use a raise of hand as an objection to that proposal. Okay, and as Nick Ball as chair of audit, can we agree, if we agree the membership, can we agree the chairing of that? Are we happy for that to be agreed in discussion with the audit committee rather than us trying to determine that within governing body? And the audit committee can help work with Simon on the best way of getting that chaired and reporting through to governing body. Are we comfortable to delegate that to them? Nick, your thoughts?
Just a suggestion that I would be comfortable with, if it helps. Why don't we say we'll proceed with a non-GB member chair and review it in 6 months and see if it works?
That's fine. And then if we ask audit committee to do that review rather than governing body, then that would be an appropriate place to do that.
Okay.
Okay. And again, is everyone happy with that proposal? Okay, that's great. Well, then let's take that as approved for the commissioning committee. Thank you. And then Ginny, 8.2, that is, so this is the revised terms of reference for the Ambulance Joint Commissioning Committee. This came through electronically to governing body a few weeks ago because we certainly the lead commissioners for that needed to get that approved, and so it's come to us just for formal ratification. Is that right?
Yeah, we approved it at governing body some time back, and then subsequent to that there were a couple of very small amendments made to the terms of reference, so it just came back to us for approval. So we took it out to members came back and approved it, so it's just here for ratification and for noting that decision was made.
Okay, there were no objections at the time. I'm just going to pause briefly to see if there are any objections to it now. Penny, you've got a question?
So I'm going to the next committee meeting anyway, but I think I was just concerned that clause 9.5 and 11 need to be linked so that there is no question about any decisions being made in abstract without with the total budget agreed for spending on the ambulance service. But I can clarify that at the committee.
I'm happy for us, rather than for you to do that on our behalf at the committee, rather than us have to do anything formally in writing, and then for you to report back to us if you've got any ongoing concerns.
Yep.
Apart from that, no. Apart from that, okay. So there's no other hands raised, so let's take that as approved by governing body. Thank you very much, everyone. We're now on to section 9. So that is our committee reports. So let's start with Primary Care Committee. Judy, we have the report in front of us. Anything you wish to highlight?
Sorry, nothing to highlight. Very happy to answer questions if there are any.
Okay, any questions for Judy? Okay, thank you very much, Judy. And then Glynis, Audit Committee, we've got the Chair's report. Can I actually, people will have been emailed this morning a slightly updated version of the audit report. Ginny, for those who won't have had access to that, whether they be members of the public or people not able to access their email, could you just highlight for us the difference from that? Glynis, yes, and then we can open up to comments if there are any.
So we're talking about the Quality Assurance Committee report.
I am, yes. Sorry, I realised I said Judy, I meant Glynis, sorry, apologies for that.
Okay. So Quality Assurance Report Committee, there were a couple of things that the committee wanted to be brought to the attention of the governing body. A couple of things from April, which one in relation to the financial support to the Autism Improvement Project, which appeared to be ending in March, and I think we wanted to know whether that was going to continue. And then the issue around the SIs for DPT, which we've already discussed earlier, and we know that there's some additional work going on there. But there was also an issue from the March meeting, which is in the which was missed out in the report that was sent out, so it's been added in, and that was in relation to a patient experience presentation that we had at the meeting from a woman who'd experienced 2 terminations of pregnancy on medical advice, and she'd had a markedly different experience within the same trust. On one occasion within a midwifery ward, a maternity ward, and in another occasion in a surgical ward. And the committee were concerned about this, partly because there seemed to be an 18-week cut-off, which depended on which ward she went into, but I think primarily because of the attitude of staff and the way in which she was treated in those two different settings. And I think there was a feeling of the committee is that there should be potentially there's a need for some training there, not just within that trust, but possibly across Devon around some of these issues, because the perception of the trust that we got back in the meeting was that this was about facilities and having bereavement suites and so forth, and actually it wasn't. It was about the attitude and approach and the culture in those 2 different settings. Charlotte, you might want to add to that because I know that you were concerned about this too.
No, I'd agree with that, Glynis. I think Sheila's probably going to come in as well, but I think very much what struck, well, I think, thank you to that patient as well, because what they shared was incredibly painful, and it was very brave of them to come in and share that with us. And I think that's why we also felt compelled to share this. But yeah, I think very much for me, it was about the culture and how things could be done in a cultural way to improve. And I think that's what she was reflecting in her story, not necessarily some of the actual equipment or the ward as such, right down to kind of reception as well as clinical staff, the difference that she received.
Thank you. Yeah, I'll bring Sheila. Firstly, there were lots of confused faces at me because I did get that completely mixed up. We will come back to Audit Committee, Nick Paul, so apologies for that. Sheila.
Yeah, I just wanted to add, I think that that the issue here is not one that the patient felt that she wasn't well treated. The issue was that in one situation she felt she was treated as a mother, and in the other she was treated as a patient, and she felt that that was very, very different experiences. And I think some of us listening also wondered whether, well, I certainly did, and I think it was generally agreed there were potentially some dignity and respect issues there, Darren. So you know, the ward she was on for the second admission was a mixed ward, and there were some male patients on the ward as well. So some questions were raised for us about dignity and respect, about whether this is an arbitrary cut-off, and about whether the trusts are doing everything that they can to support women. So, for example, could a midwife be used on that gynae ward, which would change the flavour quite significantly rather than a gynae nurse. So there were lots of questions, and I think that it has been taken away, but we wanted to raise it because we felt it possibly wasn't just in one trust.
Darren, and then it would be useful, having heard the story, just to know what's in plan in order to try and take this as learning and a trigger for change if necessary.
Yeah, thanks, Chair, and thanks, Sheila. And I'm probably going to hopefully answer your question, Chair. So obviously, I know a little bit more about this particular situation because it was a provider that I'm very familiar with, and I think we can give assurance that the pathways have changed, and there has absolutely been significant learning from this particular case. But I think you're absolutely right that actually this is probably a situation that's repeated across all of our providers. So this is a conversation that I think we need to take two ways, probably one through the chief nurses around patient experience, which I'm happy to do, but also I'm wondering whether this is something we need to be taking. It's probably not quite in the LMS portfolio, but it's probably got the right people in the room to have those conversations.
Okay, and Charlotte?
I just want to say, can we make sure, if they haven't already, that those changes can be fed back to the patient who shared their experience, so they know the difference that it made?
Yeah, they're absolutely, Charlotte. I will just double check that, and if they haven't, I'll make sure that's been fed back.
Okay, so Darren, the action from this, can we leave that with you to ensure it happens?
Absolutely.
Yeah. All right. Thank you all, and thank you, Glynis. And that must have been a very sobering discussion, but hopefully a productive discussion that you had within the committee. Any other questions for Glynis on that, the Quality Committee report? Okay. Thank you. Nick, then apologies again. We'll go back to the audit report.
I don't have any comments to add to the report as it stands, Chair. I'll take any questions.
Okay. Anything for Ginny?
Just like governing body to note that attached to the audit chair's report is the COVID risk, the corporate risk register, and the COVID risk register. The COVID risk register that you've got attached is not actually the one that was reviewed by the audit committee, because we are reviewing it on a weekly, but have been reviewing it on a weekly basis. So that was out of date. But it's just to note that that has come to governing body in case anybody has any questions on that.
Okay, thank you. I won't spend time with us going through the risk report at the moment. I will give us a chance because we've got the locality updates that often do get squeezed out. But let's move on to those at this stage, if we can, then please. So I'm just seeing which one we've got first. We start off in the north of the county. So John, Charlotte, and Andrew.
Yeah, thank you, Chair. So I'll take the report as read. I think I'll just re-emphasize that it's been a heartening time to be working in my locality and in other localities, I am sure, to see the collaboration and cooperation between providers, multiple providers, and CCG members, and the speed at which we've got things done, the focus on the appropriate issues, I think has been heartening. And I think we've heard those conversations throughout the day, and I think at locality level, that's been true as well. So I'll take the report as read and just answer any questions that people may have about what's written.
Thank you. And Charlotte or Andrew, anything else to add on that report? No. Okay.
Thank you.
And any questions for John?
Okay.
Okay. Thank you very much, John. We then move over to the east of the county, not the country. Simon, John and Glynis. Well, I think John has had to go to another meeting, unfortunately, but it's Sir Simon and Glynis.
So thanks, Paul. I think I'd say the same as John, take it as read. We are working much more collaboratively than we've ever done, and I think virtual working has enabled that. One example of that is this report actually was the first one that's ever been constructed as a team effort. So it reads probably slightly less focused around my issues and around the issues and the kind of the recommendations of the locality team that I'm working with. So just to report that we have a tactical call that meets, in fact, it's about to meet in 5 minutes every week, which has been, I think, very productive, which the RD&E attend regularly, community teams, social services attend those meetings as well. And we've got 3 representatives now of primary care from our 3 sub-localities and myself as well. And that's starting to move forward with building joint working together. So we've had some good examples of that around early discharge for patients that have had COVID, where we've had standard operation procedures built together with primary and secondary care, jointly working around that issue. We've got to do a lot more, and I think we've got a format now for doing that, which is really encouraging. We've got some good working going on in the emergency department in the RD&E with Andy Wood, who's the clinical lead for one of the PCNs in Exeter, working with the emergency department consultants at the RD&E. So I'm looking forward to some exciting new changes there. And I think a willingness from the RD&E to do some different things with regard to working with the NHS 111 CAS around that as well, which is, again, quite exciting. So take it as read. Any questions? But I think on the whole, there's some positive forward movement in my locality.
Thank you very much. Nick Kennedy, got a question.
Thank you, Simon. Yeah, you said that that tactical call's been going really well, but in your report you highlighted it as a risk, saying that it needs trusted relations. It's unlikely to be in time to meet requirements to develop system work. Or have things moved on since you wrote the report?
Well, I think that there's always a risk there about whether it's going to work. There are some, as I think John Walmsley highlighted on a call yesterday, there are some concerns in primary care among some of the primary care networks about a need for more resources and more funding to enable them to do things that they want, what they wish to do and that we wish them to do. And I think that sort of culture is very contagious and is spreading a little bit into my locality as well. And what I've been trying to do is encourage my fellow commissioners to take an approach with our colleagues in primary care that we've got to work collaboratively and that we've got to work transformatively rather than transactionally. So I think it's going to be about the way we actually manage that tactical call, the way we talk about things and the way we try and steer conversations rather than getting bogged down in conversations about having to provide more money and resource for more work. What I've been trying to say to my commissioning colleagues, let's have a conversation with our GPs about how do we work together, because they're more likely to move money out of secondary care services, which are very much more expensive, into the primary care arena if we have conversations about transforming our service rather than saying you've got to do this extra piece of work and we're going to have to try and find some money to make that happen. So I think it's about how we do it and how we take a leadership role in that tactical call. will be how it will work going forwards. At the moment, it's working, but I think Tim Golby and I are very wary that if we don't continue to manage it carefully, people might not turn up, might not join, and it might not be as productive as it currently is.
Okay, thank you.
Thank you, Simon. And I know lots of conversations have said that we've developed some really good relationships through a lot of this remote working and the ability to engage. And there will be definitely an onus on us to make sure that we continue those, that we build on them, because they are going to be so crucial to the sort of things that you've talked about. Thank you. Glynis, did you want to add anything to Simon's comments on the report?
No, thank you. No.
Okay, thank you very much. And then we move to the south. David Greenwell is at overview scrutiny at Torbay, but Sonia has rejoined us. And Judy, apologies, you should have been there on the front sheet of that report. So I don't know why that's happened. I'll find out and I'll make sure it's not a recurring theme. So apologies for that. Sonia, is there anything you wanted to draw out?
Yes, so first of all, yes, sincere apologies for omitting Judy's name on the paper. Clearly she's a non-executive that we've been working with in the southern locality for some time, so I do want to apologise. The bits I just wanted to highlight, so the nature of the report highlights some of the key achievements, some of the local flavour, and I think it's important to note some of the service changes that were put in place in this response. So, for example, the movement of oncology to Newton Abbot to be able to continue with really important cancer services in a site that during the time was felt very appropriate to be able to do so. Also, some specific examples around how some of our primary care sites have been used. So the report highlights some of the local issues and concerns and achievements that have been worked through, but also pretty much echoes some of the other locality challenges around urgent care, discharge, some of the achievements therein. And I certainly recognise how this period has really cemented integration in action, you know, about community services, mental health, primary care, local authorities coming together in a different way. And in another guise, one could talk about these are care partnerships that have been united in a common purpose and come together. The bit I probably would want to highlight here as well, this has demonstrated this period as well, where it's really important to work locally, but there are sometimes things that you do in one part of the system that have unintended consequences elsewhere. So we have highlighted in the report where, through really good intentions, the emergency department, in consultation with others locally, had put in a process to support a clinical triage process for ambulance arrivals, which then had unintended consequences elsewhere in the system. And we are now looking at a Devon-wide approach to really good alternatives to emergency departments, particularly in the south, which has a very small emergency department for the level of demand and won't be able to cope with pre-COVID demand levels. With social distancing and the requirements to cohort people. So there is a piece of work which Sarah referenced earlier and that was the call I was on and have just come back from, where we are looking at a Devon-wide approach to ensuring patients get the right care that they need, and we safely care for people in emergency departments as well. And that's a particularly an issue in South. They are also, the trust this is, looking at how they redesign their emergency department in a different way to be able to cope with the increased, understandably increased demand levels as we move it to a more normal state, but in a COVID world. So that's all I just really wanted to highlight. That balance between local and Devon-wide is certainly playing out here locally in the south. Judy, is there anything you'd want to add from the conversations you may have had with David and Liz as well?
So I was just going to say that we stopped having our South locality meetings during the COVID thing because the officer who was leading for us was, sorry, I don't know how to stop that ringing, forgive me. I'll sit on it. Solveig went off to work somewhere else. Liz, who we saw earlier on the mental health report, has become the officer leading on this work and has reinstated our regular gatherings. And it seems to me that she's very well integrated already and working with David and Matt regularly. I tend to come in on our regular monthly meetings, but not on the weekly things they do, although we've talked about how it might be appropriate to use a non-exec in some situations, but seems to be really getting into the issues. I've nothing to add on the issues.
Okay. Thank you both. Any questions or comments for Judy or Sonia? And in which case, we've saved one of the four best till last. West, Sheila, Joe's not here, but Sheila and Nick.
I see what you did there, Chair. Right, thank you for that. I won't expand on it. I assume you've all read the report. I think a lot of the themes that we have in the West are just echoing those that you have elsewhere. I think if I could just say anything, it would be that you will no doubt all remember that that the GP and practice nurse workforce in particular in the Western locality has always been an issue historically pre-COVID, and it has remained so during COVID times. And as we start to return back to higher levels, which we're definitely seeing in primary care, we're also seeing the hospital not yet returning to normal levels. So we're being asked, as Simon has already said, we're also in the West being asked to see more more secondary care work. That's causing some problems with patients not understanding and not liking it, which is requiring some time to deal with. And of course, a big concern for me, which I'm only surprised we haven't mentioned it already, but I've mentioned it in Quality Committee and Primary Care Committee, so I'll mention it now, is flu vaccination campaign going forward. And I think that I wish I'd put that as a risk on my report, which I didn't, or our report rather, sorry, Joe. But I think it is something that we will definitely need some help with going forward. And I think I've just seen today that Lorraine is going to be producing a paper on that, which I'm pleased to see. Thank you, Chair.
Right. I think you're absolutely right. It is one of those priorities. Yeah, but it's good to know that Lorraine's doing that. So we look forward to seeing what those plans are. Nick, anything else that you would want to add to that report?
No, thanks, Chair.
Okay. Great. Then I've got two hands before we get through to the end. So James, and then Graham, and then a well-earned whatever your reward is at the end of the meeting. So James.
Well, my reward is another meeting, but just wanted to make the point that I was pleased to see in the northern locality that suicide prevention work is a key area. And I just wanted to ask, it wasn't mentioned on any of the other localities as being an area of work being looked at. And I just wonder if there's any sort of Devon-wide initiatives that can be tapped into around zero suicide initiatives, and how we can, especially given that we're anticipating an increase in suicides, how can we work together to work on prevention?
So the key people, which would be Liz or Joe, aren't necessarily here to comment on that. I don't know whether one of our other executive colleagues or Simon could.
Yeah, hi. So I'm not trying to pass the buck in this, James, but obviously it's so public health and local authorities are the lead for suicide prevention. We are working with them as part of our mental health STP work. As you've said, we've seen an increased prevalence over the last 6 to 8 weeks. I've certainly seen serious incident reports come through, and I think Darren and Philip referenced that earlier. So we have to make sure that we pick that back up again. So more than happy. I think, are any of our DPHs still on the line? It's work that we need to pick back up again now.
Thank you.
I was just scanning through. Tracy is on the line. Your last contribution, Tracy, to our governing body, if there's anything you want to comment on that.
Yeah, unfortunately, it's not an area I'm particularly closely involved with. I do know that they are working hugely on it at the moment, and they're just completing the suicide audit. So it's one of the things that we've kept going during COVID. So Nikki Glassbrook's in there, and that should be finished within the next couple of months. And I think there's quite a lot of recommendations that will come out of that. So it's certainly not something that's gone on our back burner during COVID.
Okay, thanks very much. And then Graham.
Paul, thank you. I just wanted to say these 4 reports are really good, and I really value reading about the 4 geographical areas, and very often in our meetings we're under so much pressure they get squeezed at the end of the agenda. So it's great that we've had time to do them justice today. 2 of the reports talk about redesigning ED to allow social distancing. I presume that therefore might reduce the capacity of ED. And Sheila mentioned the point that in her area, the GPs are picking up fallout from ED. So do we think that trend is going to continue and that GPs will be picking up fallout from ED because of the reduced capacity caused by social distancing?
I think that's a really good question. I'm just looking for people to... Simon, do you have a comment on that particular one?
Yeah, I can respond to that. So I had an interesting call with Adam Rubin, who is lead for ED in the RD&E last week, and with Andy Wood, who's our GP in Exeter, who were working together on that. I think there is a great concern in the emergency department of Exeter about exactly the point you make, Graham, difficulties with managing that number of patients coming through the department with all the restrictions that PPE puts on them. I think that, that's really one of the reasons why they're looking to see if they can put a lot of calls through the 111 CAS, so people will be able to get to ED either via ambulance or by making a phone call to 111. And the thought is to perhaps having some surgeons and some emergency department consultants, possibly some orthopedic surgeons, answering a lot of those calls by telephone and saying, yep, you can either come to Casualty now, or you can come to one of our clinics later in the week because you don't need to be seen today, and trying to manage a lot of the demand in that way so that there'll be less people necessarily coming through the emergency department itself. So I think some innovative ideas, whether it will work or not, or can work, and whether we can do that with communication to the public, I don't know. I think there are implications also for primary care. There's long been a thought, I think, that primary care is having some of its work done in the emergency department, particularly from practices in Exeter, and that will be a difficult communication to have with some of the practices in Exeter. But I think that we do need to change the way we work, and possibly the limitations of PPE in the emergency department are going to be forcing that change, which is long overdue.
Yeah, Sonia, did you want to add to that?
Yeah, so this is very relevant because this is work that we're working on at the moment. So nationally, there's a Think 111 First campaign and movement, and obviously in Simon Stevens's letter to us in terms of our next phase in restoration, there's an urge to enhance the capacity of our UCS services. So that is absolutely what we're working on, and then thinking through, and this is why we're in dialogue with DDoC and others as well about, so if it is 111 First, what are those mechanisms, those alternatives that need to be put in place, whether they're hot clinics or others. And I know Adam and Andy Burgess are very much involved in that conversation, as all our trusts. And I guess the other thing we need to think about then is, given that we have a good experience of virtual working and some of those things, if access to secondary care advice is needed, does it always have to be physical, or could it be virtual? And then therefore, do you not need 4 of everything? Could you, share resources in some of those hot clinics and other things if it's virtual as well? So all those things are just the operational implementation of that Think 111 First is something we're just working through. We have a relatively small window of opportunity now before we move into the winter, so that is absolutely one of our priorities. And of course, just picking up the small ED department conversations, there are capital bids that we've got in a couple of our trusts, so UHP and Torbay and South Devon, and capital monies that we're putting in as well, because there's some infrastructure changes that need to be put in place as well.
Thanks. And Simon, this goes back to your verbal update around recovery, transformation and service change, doesn't it? Because that's as relevant to our acute emergency services as it is to some of those elective pathways.
Yeah, it is. And the other thing I was going to say, Paul, is that it might be wholly appropriate for there to be a transfer of work from EDs to primary care, but it has to come with the associated movement on of people that shouldn't be attending primary care in the first place, because there needs to be a shift in terms of capacity. It's all about making sure people are at the appropriate place, isn't it? So we need to make sure we do all of this. It's no good doing one bit of that work without the other bit as well.
Thank you. And I think that now is my reflection on that is that now is a good time to do that, that people have the NHS is in a very good place as far as reputation is concerned because of coronavirus, that our public have got used to managing a lot of things themselves rather than necessarily relying on the health system to provide them. And so it's an opportune time to have that message to our public so that they get medical assistance when they need it and otherwise find other routes, and that medical assistance is provided in the most appropriate setting, whether that be A&E in primary care or some virtual route. So I think there's a good opportunity that we've got, and I think it was Sonia was talking about, we've got a window at the moment to try and maximise that situation with our general public. So I think on that note, I'll close. I just do need to say that there was a question that I got through. Unfortunately, we haven't addressed it now. It came through to me relatively late from the public. It's relating to CHC, but there are some very specific technical questions in there. So for the person who submitted them, I'm going to work with the team and we will do a written response to you initially. And if you still want them raised in a public governing body, then we will do that next time. So I will end now and thank you all for your time, your enthusiasm and your contributions to, I think, what's been a hugely valuable governing body and demonstrates the approach that we're taking as a CCG to take the health and well-being of our population seriously at this time. So thank you all and have a good evening. Take care.
Thank you, Paul.
Thank you. Bye.
Bye.